Today on the Reality Pill, we have an implant surgeon, but not the kind of implants you're used to hearing about. It's nothing to do with breasts. He is a facial implant specialist. It is, I think, of great value to hear what he has to say because he doesn't like putting implants in everybody. He has a nice little calculation, an algorithm that he goes through to figure out how to balance the face better. And he's here to tell us what the reality is of implant placement, their risks, their benefits, and where he likes to place them most, as well as tips for surgeons on how to place them and really give your patients the biggest effect possible. So we'll talk to him about this, and he also gives us a little foray into the world of orthognathic surgery, which is another topic that we're going to be talking about on another podcast coming up soon. So please welcome Dr. Karan Dhir, a very close friend of mine and colleague who actually helps train doctors just as I do very, very often, and we're hopefully going to be working together more and more in the future. We share many patients, and I love sending him the cases that I just can't do by myself.
I'm Dr. Karan Dhir. I remember meeting up with Dr. Talei many years ago, and we've stayed friends and colleagues. And look at him now, years later. I get to be on his coronavirus show, as he says. So it's an honor to be here. We're going to be talking about some facial implants, fillers, and I'll kind of let Dr. Talei kind of direct the conversation. But we're going to talk about options, I hope, and go through all the different ones.
Yeah, perfect. So I personally... I don't do much in terms of facial implants. Everybody knows I do very limited amounts. And when I need anything extensive done, I always send it to Dr. Dhir because you really have to be good at this stuff in order to do it. And it's not just the customizable things that not everybody does. It really takes a lot to understand the difference between the facial skeleton and the soft tissue around it. So I think most patients themselves, when they're getting this stuff done, they're a bit misguided, not knowing what to get between fillers or soft tissue or fat or those things. So first, can you explain kind of the difference between soft tissue augmentation and bony augmentation, or how you approach it with different patients so they know the difference?
Yeah, I think that's a great way to start. Dr. Talei is very talented, and he absolutely has a good grasp of these issues already. Just so happens that I fell into the world of facial implants, and it does take a lot because it is a psychological thing with patients, as well as when to use them, especially when we have so many options. So I guess before to even begin the conversation is that, we have three parts of our face. We have the bone, the skeleton of our face, which gives us the generalized contour that has to be in harmony or well-developed. And then you have the midsection, the fatty parts of our face, the tissues, where, of course, Dr. Talei does a lot of facelifts. He's got such good talent and education there to where those compartments should be and how to raise them, elevate them, put them in the right location. As we all age, we have volume loss and gravity. So the facial structure of the skin itself, the soft tissue starts to descend. And the last part is just, basically the skin draping that comes over those the underlying structures. So the first things first is when we think about facial features, we talk about contours. So well-developed cheekbones, a well-developed jaw. So if someone doesn't have that to start with, we have to look at the general structure of the face. If they don't have anything there because it's just not been formed correctly or deficient, we have to think about how to restructure the bone skeleton so that the overlying skin and soft tissue can drape correctly and give us nice contour and form. So those are patients you always first think about, do they need something just to even get started? And let's say the options. We have facial implants, which are structural components. They're an implant that we place onto the bone. They're anatomic. They fit great, and they give us contour. That's the first thing. We also have fillers. Those are soft tissue fillers that we talk about all the time. They're dissolvable. There's something that get an instant result. There's something you have to keep on doing. You can
get kind of bony or soft tissue augmentation, just depending on where you place it.
Correct, and you're doing it for contour. So if you want to make a cheekbone, you can put fillers or fat transfer in a region to give it the contour that you're looking for, which we'll talk about in a second. And then the last one is fat, which is very much similar to a filler. It's a little bit more permanent, meaning whatever lives will live on for the time. It doesn't. Not all of it that you inject lives. So whatever does live, semi-permanent, meaning there's going to be some permanent component. So when we start talking about what's best, it's really important to know that we can use all three. You can use implants at any time. You can use fillers, but when to use what? If you have to use so much filler or fat to really make structure, you're going to be putting so much that it might look amorphous or too cheeky, and then the weight of gravity will bring it down. So if you do too much of the wrong thing, soft tissue, fillers to make up for a bony problem, you might have an issue. But you can use both in all the discussion. I think it's more important to know that what we're doing, Dr. Talei, you and I always talk about anatomy, is that you return like to like, right? So if someone has a little soft tissue volume loss, you can use soft tissue fillers or fat. But if you're really trying to do something to make up for bone, you can use a little bit of filler for contour. But if you're really restructuring, you may be in the wrong position where we should start with an implant.
Yeah.
So here's the way I think about it. You can use all three. They're all great options. First of all, look, is there underlying bone at least there? If there isn't, you're probably more likely to think about an implant, and you can always use fillers to enhance it. If you do have bone, but you want a little bit more fullness, you can use both implants, fillers, and fat. And I'll start with that. So how was that little kind of intro for us, Dr. Talei?
Yeah, no, that's great. And I think for patients who are looking at the face and learning how to understand it, and surgeons as well, yes, we have balance and harmony in terms of ratios and sizes of things and seeing whites of the eyes and whites of the teeth. And, you have all these kind of guidelines as to what to look for. But when you look at the face, you have to look at the harmony in the volume as far as being kind of top heavy versus bottom heavy, the strength of things, and the balance of soft versus bony. So a lot of people, I feel like they don't understand that. They don't see that there's a balance that we all have in soft tissue versus bony structure. If we have too much boniness to our faces, we look either big, mongoloid, like we have acromegaly, or we look bony, we look hollow around places. If we have too much soft tissue, then you look like a big, fat, nasty cherub moon face. And so,
right. Well, yeah, if you don't have contour of a face, you can look cherubic or like fat or a basketball, and you have no contour, right? So there has to be a magic interplay between the scaffolding of the face that gives us contour, structure, harmony, makes us look human. Yeah. And then you have the soft tissue around it that should drape over it really correctly to give us beauty, harmony, whatever we're looking for, or structure. And of course, that's difference between males and females and cultures.
Mm-hmm. And through this whole process, we have to maintain a natural look. We have to maintain movement of the face, and we have to maintain the balance and the delicate nature of the face. So we're not, somebody who wants cheek volume can't just keep adding volume. You have to look at really keeping it same size and then contouring and doing stuff like that. So, talking just
and
about...
And I love that you said that, because I think ultimately a lot of patients want to always say, what's the right option? And I think we're going to be doing education is always best if we have options, which are fillers, fat transfer, implants. When to use them, we try to sound very educated as we teach people. But the point really is, it's not that hard to anyone to just put a needle in someone's hand and have them inject the face. It's not the process of truly just injecting that's the problem. It's the art. It's the understanding of the layers of the face and what you're trying to do. You do, when you put filler in the cheek region, you do get better contour. And I don't know if you agree, Dr. Talei, but you also get a little bit of a lift, right?
Yeah. You get a little bit of volume distension.
Right. And I think that's really important, because back in the day, just I would say 5-10 years ago, when we all were starting out, remember nasolabial smile lines was very hot. Let's just inject the smile lines, and everyone's walking around like this.
Yeah.
And what we've done is we're adding more volume to the area where gravity's pulling it down. That's not right. We want volume in the mid-face for humans for contour and sexuality, whereas primates wear them in the lower third. So we started injecting here to get a little bit of a lift, and then we don't mind then injecting guys or a little bit of the smile lines or a little bits, but most of the volume's here. But if you don't have a cheekbone and you're putting a lot of filler here to get this so-called lift, we're going the opposite direction now, where we're getting people looking really, really cheeky. And not with contour. So that's why it's really important to know these options have limits.
And when we're talking about implants, which we'll go into, we're talking mainly about cheek, jaw, chin,
and then wrap around.
Okay. Do you ever do those orbital rim ones?
I wanted to talk to you about that. That's a good question. We can probably start in the mid-face. As we get volume loss and gravity, we have the cheek region as well as we have the volume here. Yeah. There are, for everyone out there, people do put implants in the lower lid to try to bring some volume or to reconstruct this bony part that gets hollow. There is a nerve here, so that makes it a little bit more technically difficult to wrap around it. They do custom implants around it, but in general, it's thin skin, and I think that's kind of gone in and out of favor. But how do you feel about the lower orbital rim?
It's such a sensitive area that I always worry about impairment of lymphatic drainage or reactivity to anything there. Unless there is like a defect, or you do very gentle, small amounts of things. So I tend to use lifting, very minor amounts of fat grafting. And if there's like a cancer defect, I tend to use soft tissue grafts, meaning dermal fat grafts, kind of to contour it and then pull skin over it.
I love that because I kind of agree with that. In this region, I think it's technically savvy. There's nerves there. There's thin skin. You have lymphatics. Some of us, all of us know that when we do tear trough stents, having filler in the right position, you sometimes get swelling or fullness in the morning just because of lymphatics and you get that fullness. Yeah. If you have an implant there, even though you placed it well, you might get some problems with more puffiness, et cetera, et cetera. So I've agreed that with the cheek implant, I often do fat transfer here, or even with, facelifting, we also put fat transfer under that region. So I've used fat grafting as well for this region.
Yeah, and how do you decide between, because I do this a lot too, where I think, okay, should I send them to Dr. Dhir to go get facial implants, which, I think they're kind of, it's like you have an engine and you're just doing little snap-on parts. And so it's quicker and easier, not a lot of downtime. Or do I send them for orthognathic surgery where they kind of have to take the engine out, rebuild it, and then kind of, work on it, put it back in. So how do you decide between orthognathic and implants?
Yeah, and I think that's a really good question, especially when it comes down to jaw work. The first question all patients should know that we're going to ask, and all the surgeons out there who are watching, is teeth function over form first. So how your teeth fitting. If your teeth aren't fitting, overbite, crossbite, underbite, at least a consult with an orthognathic surgeon to see if there's something necessary to build the function of the teeth. So if you have a recessed mid-face, you might have a problem with an overbite, underbite situation. So that's the first thing. So function first. Mm-hmm. Orthognathic surgery may need to develop that area so when the teeth are fitting. If the teeth are fitting, then you just want to look at development, basic development. If you feel that there's some deficiency, you might want to consider that option. Then you move on to the next step, which is, do they have a facial descent? Well, Dr. Talei, I've seen her in facelifts. You do a great job bringing the soft tissue up, and you do get an augmentation of the cheekbone region. Mm-hmm. Yeah, so you may not need an implant. And then, of course, we talk about fat transferring here. If someone's deficient through cancer, or you can really tell they're hollow and flat, that person may be someone I would consider doing an implant on. Again, it goes down to you need to have structure first. If you're missing structure, implant from the beginning. Or orthognathic surgery if you don't have a function.
Right. So let's say we're putting orthognathic patients aside, and then people who need fat volume or lifting aside. Now you're at implants.
Now you're at implants.
So I want to go kind of one by one of the implants to look at the pros and cons of getting that implant. So, and that includes, include people who look fake, include infection, include anything like that. So just starting with like the cheek implants, what are the problems you've seen? What are the risks you advise patients of? And who do you think is like the perfect candidate?
Okay. I think it also depends on what procedures we're doing in tandem. So if you're doing a facelift procedure and they're a facelift patient, so let's put that at one side of patients. Obviously, you get a great lift. I've seen it. You can do fat transfer in the region to further augment or make a cheek region look beautiful. If they're truly weak and they're missing, and there's three types, one's missing a cheekbone, one is missing both cheekbone and is really flat right here, or they have a great cheekbone, but they're so flat right here. And that's an orthognathic patient, or you need some more fullness here. So first we think about, if you're doing a facelift, would a cheek implant better drape the soft tissue for the patient? Then maybe a cheek implant to build it, and then you do what you do magically. If a patient does not need a facelift and just coming in for evaluation of the mid-face, you first look at the cheekbone and the full flatness here. If you think that you have a good enough cheekbone, you want a little bit of augmentation and lift, consider fillers, fat transfer. If they really are weak and deficient and they really want a robust cheekbone and they don't want to do the fillers every time, if they really, really want a permanent solution, then you can do an implant. There's silicone rubber is the most common. We do it through the mouth. It's a small incision. Can't even feel it with your tongue. And the nerve is protected, and we put it, and they're designed really well. I did not bring them home with me, I'm sorry. But they're silicone rubber, and they're anatomic, where they fit on the facial structure of the face itself. And it's not like the old style cheekbones where people feel it's just a cheekbone and it looks bony. It actually fills the whole part here to lift and give a nice architecture. So that's the ease. It's very easy to put in. Risks, infection, number one, about a 5 to 7% chance of infection that can be cleared with antibiotics. Worst case scenario, we can remove them very simply in the office. You make a small incision and pull them, and then you can put them back in 6 weeks if that's an issue. But that's very rare. So infection is something to discuss, but it's rare. You can deal with it. Number two is malposition, meaning it moves a little bit. Little bits of movement should not show any problems, but there's major asymmetries, having to re-put them where they need to be. I often use a screw just to hold it in place, one size, small little mini screw that does not go off at the airports, just to hold it in place so we can bolster them. So malposition, Asymmetry. People with mid-face, and all humans are asymmetric. And I think Dr. Talei, he's a specialist in the facelifts, and he deals with it all the time. We are all asymmetric, and we have one cheekbone that is always going to be lower. I think on my face, this one's the higher one. Everyone, if they do that to themselves right now, one is higher. That side of the face is always narrower and also more projected. The opposite side has a lower cheekbone, wider and flatter. So when you put cheek implants in, you will see an asymmetry still there. Although we try to make it better with fat around it, but everyone's born with that. And that's actually human and natural. So asymmetry is another issue to talk about. So that's the implant. I'll let you jump in on soft tissue fillers and fat transfer complications.
Yeah. So the other patient that I have caution on for cheek implants is somebody with a very bony face.
Yes.
And they want to come in and they want more cheek enhancement. And they say, okay, well, I want my cheek to be bigger and I want it to be permanent. And I look at their face and I say, you know what? I think you can get away with it for 2 years, 3 years. But 10 years from now, you're going to be thinning out so much that unless I keep up with just filling you all the time in the under eye and keep it, matching the soft tissue augmentation here versus the bony here, that you're never going to finish chasing it. So for those people, I say, you know what, do filler, and you do filler around here and under here, and you can just kind of do it as needed. And eventually, if you wanted to do fat grafting, you could always try that as well.
And I would argue that that's one of the patients during the evaluation why you go to someone who's trained and understands all the layers, is that if someone already has facial skeletal architecture, then they're a soft tissue patient, meaning the mid-face or skin. So then you're using the right technique. You're filling what you need with like and like. So fat transfer, soft tissue fillers, you don't need the bone. So therefore implant, maybe you can do an implant, but you'd have to put fat around it as well to fill the soft tissue so it looks natural. Right. You might need both.
Yeah, so you do have to consider the future of that patient, saying, they are going to hollow out over time. We don't want them looking too bony, 10 years from now or anything.
If they're soft tissue dependent, if their soft tissue has kind of regressed or if they just don't have it deficient, then you have to have a soft tissue conversation as well as the implant. Either do soft tissue alone, or if you want both, you better do both. You can't just do the bone itself. You'll make the problem worse.
Yeah. And do you do customized cheek implants?
So basically, in the last series that we wrote a textbook on it, for prefabricated implants, now we're in a lucky stage of technology that they're designed really, really well. They're not just a cheekbone component. They're actually designed with 3 parts. You can do a cheekbone and a little fullness here. We can do just the fullness if someone has a cheekbone, but they have loss of volume here, or you can do the whole implant. So there's different styles of implants we can choose from now, and they're pretty good. The only negative about cheek implants is that asymmetry. Someone has major asymmetry, I would use custom because the computer can at least make up for that rather than just doing 2 the same size. So number 1 is major asymmetry. Someone who's deficient, not just from the regular aging process, so wants to look a little bit bigger. Patients who are truly deficient, you probably want to get a bigger implant. So that would be a custom implant. But in general, cheek implants for someone who has a normal face and regular desires, an implant is just fine with fat transfer and fillers.
Okay, cool. So as far as chin implants go, I try to tell patients that's the one that I have like the lowest threshold for, meaning it's the one that I just kind of, if they even think about saying, well, you know what, I've done chin fillers and I like it, I say, don't even bother with chin fillers, just do the implant. It's local anesthetic case. It takes, half an hour. Your recovery is quick. Your risk of infection is super low because I do them all external there.
Correct.
And
I would like to even add, to add to that great sentiment, which I agree with, is that I think that the chin implant for mostly all the rhinoplasty specialists out there are very, very good at being with chin evaluation because they go together. Yeah. So I think you're a rhinoplasty specialist as well. So of course, chin implants is something that's in your arsenal to use. Chin implant is the most, I feel, single powerful procedure outside of the nose to change someone's structure of the face. It does 3 things that I love. Number 1, it gives length to the face. So, our basic thirds, if you're weak in the chin, you have a very small, weak under third here, and you look younger, which is not always good. You might look younger than your stated age, and you want to look more, your stated age. So you get a length in the face, number 1. Number 2, that projection has a good balance of the face, thirds. And then lastly, it drapes our neck because facial skeleton drapes skin. You get a better neckline, so it doesn't have that waddle. You have a better sharp angle here. So those are the three things you see. So I think the chin implant is one of the most powerful before and after shots in harmonizing of facial structure. And the risk factor, risk to reward is so low. The reward is so high compared to the risk. Like you said, I think I use an external approach too. Under the chin here, a small incision. The nerves are well saved. They make such great chin implants, prefabricated now, sizes. I do my projection. Basically, I have my own rules. Every surgeon has their own ones. I like to match it up to the lip line for men, a little bit behind for women to keep it a little bit on the weak side. Number two is width. I just look at inspiration photos and I see which tooth that they kind of like on celebrities or a family member. And then that means I can carve it. And then there's shape. There's only really 4 shapes that I kind of discuss with patients. And I've been dying to tell you this, Dr. Talei, to see if you agree. It's really funny, like, because only people who do implants or want an implant can understand it. Right. It's either a square, square, oval, oval, square, or oval. Like, those are the shapes. Yeah, someone wants a little over with a little squarish, or squarish with a little oval, or the extremes.
Yeah, and the way I look at it is actually similar, and it's about where it's tapering, which is what you're kind of describing. So I look at broad, narrow, tall, short, and I kind of mix them exactly. So I see, do they want to just be
right? It's a mix, right? So that's why you made it the same thing. It's like you have your extremes, and then you have the blend.
Yeah, exactly. So I would say it's safe to say that it's extremely rare that the chin would ever have a soft tissue deficit. So most people just need the chin implant, which is also why I jumped to a chin implant versus injectables there, because what patients don't understand is that injectables are soft tissue augmenting volumizers. So when you put one syringe of filler on the chin, you're okay. You can keep it on the periosteum. It blends into that soft tissue plane, but it won't make the chin heavy or bulky. But if you keep adding filler to the chin or fat to the chin, now you're going to get either a witch's chin or a big fatty kind of meaty chin. So I think there's a big downside to doing too much filler or fat, which is not as predictable in that area. So I just love the implant.
And I think for all the people that are watching, fillers is the magic that we all hear about. In the chin region, it goes right back to, is there bone or is it soft tissue deficiency? And in the chin region, we're usually developed with a pretty good chin button, this button here. And by doing a little bit of filler, you can get away with a little bit of augmentation. It might make the neckline look good for just rejuvenating. But if you truly need a chin, he's absolutely right. The more filler you put, the more you're making up for the wrong thing. If you're bony deficient, you're putting too much soft tissue and you will get a sag because there's nothing to structure to hold up the soft tissue.
They get masculine. The girls get masculine when it's like that. Yeah. They get
and it's very hard to control the width, what you were talking about, the contouring. They look very meaty and wide. It almost look like a linebacker look, like this, football player.
Yeah, it reminds me of Mickey Rourke's chin in the movie Sin City.
Yes. So they made that very augmented. So I think chin implant's great. Again, I think the chin implant is just a spacer to move our soft tissue into a proper position. So it's more like just building bone. Someone wrote a great question. What about bite problems? If you do have a bite problem, I get an orthognathic surgeon involved because they may need to saw that bone to bring the teeth together. And then I can do a chin implant after it's all healed. Or sometimes you get enough chin from that surgery that you don't need an implant. That was a really good question. Function always first before form.
Yeah.
So chin implant, go ahead.
And as far as a technical thing goes, we do a lot of revisions. And so just as far as the question, I'd say if you're looking at large numbers of surgeons doing cases internal versus external, meaning incision outside versus incision inside, nearly every single revision that I have to do, the incision was made from the inside. And you get migration, or it is sitting in the wrong plane, or in one place it's in the wrong plane, the other it's in the correct plane. But mainly migration, and it's vertical superior migration. As the chin moves like this, it moves into a pocket higher and higher up. And they never really dissect down far enough. So that's what I've found. I don't know if you found the same thing.
Yeah, I think I've found, well, first of all, it's patient what their desire is. It's an art again, right? So number one is they just don't like their look. They wish they went bigger. They wish they went smaller. The shape is wrong. It moved. I have numbness. There's always some issue. And I think you're right. That's something you and I should probably look through our numbers and get a study done of the revisions, which approach was actually made.
It's like 90% internal.
Yeah, I'm feeling the same way. And the reason is there's this so-called discussion of going incision here, which hides on a crease. No one sees it, versus going inside. Why would I get an incision outside? Well, number one is you guys are going through the mouth with an implant. I think infection rate is something to consider. Number two, there's a muscle that we all have this muscle right here, when we smile, it helps pulling down the lip. It attaches pretty firmly to the bone. Some people have it so well developed down that way that they have a huge crease, and people always want me to fill it or make it better. But the point is that that's a normal thing that we have, this groove, this sulcus. When you go to the mouth, you release that muscle, and I have a feeling that it comes up, and it always looks more height-wise and more brawny in that region. And when they smile, it's been released, so the implant can ride upward when it should be sitting at the bottom border. So I'm having problems with malposition of people who have it through their mouth. They didn't get the shape that they wanted because now they've kind of messed up the normal architecture of their.
And I've seen some synkinesis too with malpositioning. So people's chin, the muscles start to compensate, or the nerve is irritated or aggravated, and they start to get dimples in their chin, or synkinesis, just muscle twitch where it shouldn't belong.
That little orange peel look that people come in, they see the dimpling and stuff, and it moves asymmetrically. I've seen that as well. Yeah. So we both agree, I think, that external approach is the way to go. Chin implants are powerful. When to use a custom for just this part? Someone, just remember, if you have major asymmetry, some patients I've seen who have a tilt to their chin. If I do an implant, it's going to widen it to make it look straight. So you may need an orthognathic surgeon to straighten it, and then I can augment on top of it.
So that's a great thing that a lot of surgeons don't get. You shouldn't go fix a major bony or dental problem with an implant. You have to get it fixed properly from underneath first. And I've seen it so much where I've seen 2 implants on one side doubled up to try to fix an asymmetry. And then you go, first of all, they move weird and they look weird. It doesn't taper or contour properly. And then their issue is still there where they're deficient on one side of the jaw still.
So if someone does have, chin implants, I think him and I both seen the same thing. It's a great, powerful thing. They're prefabricated. They do great work. We carve our implants. Him and I both do that to try to get the better shape. I think every surgeon should learn how to customize their prefabricated. So you don't need a custom unless you want it. However, patients who are shifted to one side, a custom is fine if you're okay with you like the side that's shifted and you want the other one to be as wide as that. Then I can do the computer process. I get a model CAT scan, and the computer will just add the rubber on this side so it looks symmetric, and I can click that on. So if you're okay with a wider one. However, if you don't like that width, don't do the wrong thing out there. We actually need someone to saw that and slide it over to give you a proper midline, and then we can do an implant on top, custom or prefabricated. That's a good point.
Yeah, and that's appropriate treatment. I think the other thing that I do with chin implants that you do also is that we anchor them. And a lot of the migration I've seen is people don't even throw a stitch. And the minimal I'll do is I'll throw like 4 to 5 periosteal sutures holding it down to the inferior border. If it's a revision, you can't always do that. So I either put a screw in place directly in, or I put a drill hole and just throw a stitch through the drill hole, which is kind of mimics the periosteum. But I always anchor it because even if you make tight pockets, this is an extremely dynamic area. It can move, it can shift one way or another. So I always try to do a little bit of an anchor there.
Absolutely. I think for anyone out there who is watching for learning purposes, but for all the patients out there, anytime a facial implant, if we want to use a screw or tack it down, don't even question it because it's actually better. It secures it in place, and we use small screws and stitches that sit in place. But I usually use 4 to 5 on the bottom, on the periosteum as well. Yeah. I use PDS. Do you use permanent? Or do you use...
I use 5-0 Prolene.
You do use a permanent?
Yeah, because I'm throwing the implant right there anyway. So I throw 5-0 Prolene.
That's true.
And then the mentalis, I close the mentalis back up with a PDS. And that's another big problem I see on revisions is that you get a dehiscence because people the doctor didn't put the mentalis back together, and then you get a soft tissue indentation, or you feel the implant, or the chin can ride higher now because the mentalis, as much as it's inserting here on the sulcus, it's also inserting down here below platysma. And if you disinsert it here, the chin doesn't get that down pull anymore, and from the side, they end up riding
up. Yep. Yeah. Reconstructive mentalis. Sometimes I even go to platysma and I put some sutures just to tighten the neck a little bit, just, some little mini platysmoplasty. And then I always bring that platysma mentalis up and reattach it to make it even tighter here. Yeah. So I can do that. I think that the screws for revisions, I've done that. 2 screws, hold it in place. I love that. Drill holes if you need it. I think that's a great idea. And then lastly, reconstruction the muscle. Revisions, if they've done intraoral, I try to see if I can throw some stitch in this region to try to bring the sulcus back if I need to, but that's a losing effort.
Yeah,
and then I do want to get your opinion, if anyone else, we'll do it very quickly because I know a lot of patients are on here. Big pocket versus small pocket.
Well, What I like to do is actually in the front, I like to loosen up as much as possible so I can redrape over the implant well. So I always make sure that the central portion, which is where the majority of the projection is happening, I'm never going to have something where the implant's pushing, because then the skin will push the implant back down, or the implant will be pushing the muscle and everything back up. So I make sure the pocket here is nice and open, super periosteal, and then my pockets laterally are pretty tight, just because I don't want to get vertical migration of the tail. But that's it. I mean, I like to leave periosteum down as much as possible up to about here, and then subperiosteal just for the tails.
Why do you leave the periosteum in the center? Just curious. I was just taught by tradition to go subperiosteum.
The periosteum in the center, I just feel like I have the periosteum always there to sew to, and then the hope was that your rate of bony resorption is going to be less just by keeping the periosteum intact over the bone.
Gotcha.
And I've never seen any regression or loss of bone on mine. It can certainly happen with or without periosteum, but the ones that I've seen that really have those deep ledges on revisions are the ones that they went subperiosteal, and then the implant starts to on the side just work its way into the bone.
Right. I think that's one thing we'll move on quickly, but yeah, periosteal resorption, something to talk about. I was taught to make big pockets because of three-dimensional scarring coming down. You can get movement and buckling of the implants. If you keep it open and it comes down evenly, that it stays in place. But you're right, the tail can come up. If it's too tight and you get to fibrosis too fast, the capsule is forming. That they have a capsule. You're all felt when you open it. And then if it's just like you do a breast implant, the breast surgeons always do a nice open pocket so it three-dimensionally comes down. So I was taught to keep it wide and open so when it comes down, it doesn't push or to curl the implant. So I don't know if that happens, but that's one thing I was taught. I don't know if it's true or not, but I do big pockets, wide open pockets.
And then what about jaw implants? So this is
a fun one. I was dying to talk to you about this because I think this is become a hot topic for everyone. The 3/4 view selfie. I think that I blame the world for this. The 3/4 view.
Well, first, can you confirm my suspicion that a lot of these filler photos that people are posting are, number one, they're fake as fuck. They're just all photoshopped. The other one is that even if it's not photoshopped, they're putting so much filler there that people don't understand. They just added a gallon of water to their face on the lower part. They didn't add bone. They added a gallon of water. So I do filler in the jawline, and I know what I can get away with. I do deep, I do superficial, I do very small amounts. By no means are any of them compared to, and I'm a good filler, compared to any of these photos that I've seen. And it's because most of them are fake, they're photoshopped, and then there are several that I've seen that are not fake, but they're going to look like beasts. So you took this delicate, feminine, beautiful girl that I might date, and then you turn him into this bulky beast that my brother wouldn't even do.
Oh God, poor Talei, poor brother.
Poor
little on here to defend himself. Also just to go there, it's a 3/4 view that they're even if it was real, let's say, and it's beautiful. Front view, remember, you have a fine line between lowering and widening of a face. It's not like you can just lower 100% and get that beautiful jawline. Right. You're also going to get some width. So this side view, it looks so awesome with filler. Front view, I bet you they have a little bit of beast male look to it, But I think everyone out there, I blame the 3/4 selfie view for those women who show that really well architected, jawline. It looks strong. It does drape a neck really, really well as we age and get the volume loss and gravity. If you do have a weaker jaw here, you always lose more of the neckline. So people with stronger jaws age well. Every single patient who I've met who's got a massively beautiful jaw when they're 30s, 40s, 50s, I've asked them, in high school, you hated your jaw, right? And they're like, oh, I hated it. Yeah. And I'm like, and now? You absolutely
they love it because it's nicer than all their friends.
Yeah, because it's actually kept the architecture of their neck, right? So I think that fillers are here to stay for the jawline. I do it for my patients who are 30, 40s, 50s who just want filler up in the cheek to give it a lift. I do a little bit in this angle, work it down, like you said, down to bone, a little soft tissue, just to give it a little lowering. I think definition is what the word
lower
looking
width
for.
And angling it. Mm-hmm.
And we're just defining it. We just want definition, right? We're not going for really augmentation. Right. And it always drapes the neck well. I like it. And like you said, I'm really proud of it, but if I went to show that pictures versus some of them out there that they show them there, there's no way it comes close to that. I totally agree with you. But in person, and the patient's very happy, I feel good about it.
Yeah.
But
and at what point do you jump to the gonial angle implants?
Yeah, that's a tough one. And people really are really weak, and the amount of filler that I'm needing to put in to make them look bad, that's the patient you start thinking about doing implants. Again, there's two. There's the prefabricated ones that come in, small, medium, large. I mean, that's pretty much it. They just go until here. I have a hard time with the prefabricated because everyone's jaw, this starts to get wider and more obtuse as we age. This flatness, as you can see, this guy is pretty symmetric, but you can still see everyone's got asymmetry. This flatness is not flat on everyone, and these implants are made by a machine. They're just literally sit flat, and they don't fit as well. So I'm having an issue that this is too much variance between all patients. So prefabricated implants is something to consider. They do sit in if they're symmetric. If they just need a little fullness, that's fine. But patients who are asymmetric, again, patients who really want to customize that jaw to look like someone, or they want a certain one, then I think the custom is the way to go. A CAT scan. We design an implant by the patient's desires. For example, this gentleman here wanted a square jaw right at his tooth. He wanted the Nike swoop to come in. He wanted lowering and a little wideness to get a little bit more of that structure. And this is a model, and this, if they get one edit with me, and then after that, they're involved with it. And this comes in silicone rubber. Same incision, one down here to the mouth, and it kind of clicks into place, and we put a screw there. And you can do a custom with just the angle. Yeah. You can do a custom with just the chin, or you can do this part, or you can do the whole thing. So it's an option. And there's a picture that showed up. This is that gentleman, actually.
Is it? Okay.
Yep, this is him. You can see he already had a pretty good jawline, but he wanted a little bit more definition. Fillers he tried. It was not giving him that really robust skeletal look. It was just looking full on him. He had a chin implanted in place, but he didn't like it. It was done through the mouth. And he didn't like that he didn't get that structure he wanted. So we designed this one right here with him, kind of telling me what he liked. And now you can see that he's got a lowering, widening down. The jaw is the way it looks. And I couldn't do that with fillers.
Yeah. And so I think it looks perfect. And it's something that otherwise you'd have to do a facelift to try to get that kind of accent. And it's not going to give the same contour of what you got. So I think it's like a great thing that you did there. If you could describe like quickly, what's the procedure time like for the patient for healing, like just to look good? And then what are the risks that you're worried about with, not just with those, but with gonial angles, with rotation, migration?
Procedure-wise, again, it's about a 2-hour surgery. Incision is here, 2 in the mouth, and we click it in. First week, you look like very swollen. It looks like pretty hefty swelling, but it's not too bad. And then 6 days, I take out the stitches. The first week, I'm just making sure that the wounds heal, the implant is taken in. Again, 5 to 7% chance of infection. I'm very picky on the first week. Once incision comes, the stitches come out, go back to work when you feel comfortable. Obviously, that's different for each person because you're going to look full. I do make patients sign a consent that we're not removing this implant for 6 months with me. You got to let me go through the process. I think all implants, and Dr. Talei, I always say, please promise me 3 to 6 months.
Yeah, I go crazy trying to talk to people sometimes. So it's they really do have to wait for it to slim out and show what it's going to look like. You don't know in the beginning, and a lot of patients who are impatient or they assume incorrectly what their healing time is going to be. They go make a very bad decision and then go see a doctor who, they maybe they're not as experienced, but they also just want to there's no harm in taking the implant out, and they want to do the patient. So
patient's unhappy, pull it out. But my thing is, when I meet patients, and this is super emotional, we're talking about implants and structuralizing the face. Not many people out there, we don't sell this as like rhinoplasty. It's very acceptable in our society at this stage in the game. Implants, no one really understands unless you really want it. It's very hard to tell a family member, I want a jaw implant. It's just the people who don't have definition in jaw, they're the ones who know this feels. So it's really emotional. I tell patients, you got to know that this is emotional. I'll get you through it, but you got to give me at least 3 to 6 months before you tell me to remove it. That's because a lot of the swelling sits in this region and in this region. So you look a little fuller when you wanted more definition. It does shrink wrap. I use the word shrink wrap a lot in my practice. I want that skin to shrink and define itself. So it takes time. So people go back to work anywhere from 6, 7, 10 days, whatever they like or feel comfortable. I meet at 6 weeks to make sure that it's healing well. 3 months, you'll see the first shrinking. 6 months again, and 9 months to a year for that final take. Malposition, all those things we talked about already. And I do put a screw. So
and no chronic drainage issues or anything like that?
You do, for the surgeons out there, yeah, you can get seromas, you can get unhealed wounds. You may have to pack it for a few weeks. If that doesn't work, you may have to pull it out and put it back in 6 weeks.
And what's the revision rate with these things? Because the customizable ones, you put a significant amount of effort into designing it. So it's not that you're just playing it by ear during the surgery and kind of picking it yourself. You've really gone through a great deal of work to get something precise. So
Right.
Is it a lower rate of revision when you're doing those?
So to be honest, we do maybe 1 to 2 a month because they're pretty specialized things. So the numbers are low. There's probably been about 50 or 60 that we've done over the few years now. Revision rates are very low. I mean, malpositions, maybe having to go back in and just put it back where it needs to go. That's one thing. Revision maybe is too wide, carve it down a little bit. Mm-hmm. Truly having to redo it because one patient said that now that they understand it, they wish they had made it a little bit differently, a little bigger. Et cetera. So maybe because patient desire, again, that's still a good relationship with the patient. They just want to change it up a little bit. But the revision rate is very low for anything specific because it's so customized. It's the best we can do. And
what about your just generalized feeling on Goretex versus Silastic versus Medport? Because Silastic, I feel super comfortable with. Goretex, when I've seen it, they just kind of place it in the wrong spot. So what kind of visceral responses do you get to these things?
Well, I think you and I, since we do revisions, I think our first unfortunate enemy of the state is Medport. Yeah. For everyone out there talking about there's implants are made from different things, we want it to be less reactive, almost no reaction to the body. I personally think easy in, easy out, just in case there is an issue or revision. So easy in, easy
100%
out.
100% agree. 100%.
And lastly is get the result that we all want with the minimal amount of scarring and healing process. And I think that's pretty much every surgeon's hi beauty broker. Everyone's kind of wanting that. So the three options we just talked about is Silastic or silicone rubber. It's inert, meaning it doesn't act in the body. It encapsulates well. It's easy to take out. It's been a workhorse in surgery, and silicone is the workhorse for implants. It's not a gel. It's a rubber. Medport is one designed, quote unquote, that has many holes in it, so your tissue kind of goes into it, so it heals as part of your body. Dr. Talei, have you taken those out?
It's hell. I don't like integration. Things need revision sometimes, and certainly I have not seen a decreased infection rate, which is the idea of having some of the pores in there is that it can osseointegrate, soft tissue integrate, and have some blood supplied to it. I don't want that. I would rather have something smooth, impenetrable, and non-reactive, where your body really won't know it's there. It won't change any soft tissue consistency. Right. And if you have a problem, you just take it out, you fix it, you put it back in. So
I love that idea. Also, it just technically, it bleeds more if you have invagination. So as a surgeon, I don't like blood. I know you don't either. I've seen you meticulously operate. The more blood I have, the more heart rate goes up. It's a bad tissue plane, which is exactly what I don't want for implants. I want to know what layer I'm in. I think you get puckering sometimes, especially when you try to take it out.
That's what I mean with the soft tissue. You get puckering with it, yeah.
And also when you remove it, I can't get a perfect plane. So I'm taking some of the capsule with it, and I don't like that look or how I feel. Also, there's a nerve here, everyone. I don't want to be having
yanking on it as you're trying to get it out.
I can take out a silicone implant in the office in 5 minutes.
Yeah.
So can you.
Yeah. Super easy.
Medport, I do need surgery. I need surgery for Medport.
Yeah, Medport is a pain. Goretex, usually people use Goretex, they're crazy enough to use Goretex. Yeah. So it means they're usually going to put it in the wrong spot as well and make a weird shape out of it and build it up.
Yeah, if anyone's fighting for Goretex, I'm like, I got to first start out. Do you know where you're putting it exactly? Why is there such a fight against Silastic?
I don't understand. Yeah. Goretex is great for ski gloves.
Yeah. Oh yeah. We can't use them this year, right? I mean, it's closed, but there's plenty of implant material and out there not being used. But I don't use it. And anyone out there does. I'm not judging you. It just for revision surgery, it makes it a little difficult.
I judge them. I'm a little more open about who I judge. You're more diplomatic than I am.
Yeah, good cop, bad cop. That's how we are. I want to ask you a question. Since we're going back to all the patients out there, I hope we're really getting down to, fix the defect, what the defect's asking for, use the right alternative. There are options out there, bone, soft tissue, fat, fillers. Then the more fillers you need, you're going to filler phase. You'd rather maybe use an implant. You don't want to use implants if you have good bone but lost soft tissue. So these are all really good ideas. But I want to ask you, Dr. Talei, back to the angle. Do you do you agree that pulling skin over a really well-developed facial skeleton gives us beauty, right? So something sagging and you're pulling your facelift patient upward.
Yeah, less shadows, better contour, better accent. Yeah.
Do you get a better neckline with patients who have a well-developed jawline when you do your facelifts?
Yeah, of course. Yeah, yes. Substantially, like the guy that we're looking at there, if a woman comes in, they're 70 years old, they have that jaw structure, my result is insane afterwards. And I can really create depth around it depending on where I put my platysmal flap and how I tack it in towards the deeper part of the mastoid versus the outer part of the mastoid. Yeah.
What do you do? How many times, percentage-wise, would you use an implant in a patient during a facelift?
It's pretty uncommon for me. Rarely my discussion usually with them, I say for the people who do need it, which I have had, I said, I can either add the tiniest bit of filler or fat, very, very small, like pretty much around the masseter deep. And then I do all the platysmal work around it to get accent. I say, or afterwards you can put a dot of filler, or you can go get a jaw implant. Most of the older ladies who are kind of coming in, they say, you know what, I like my jaw structure how it was before. It's fine. I've always had, a little bit of a weak jaw.
Right.
But there are some who really do need it, and they're the younger patients. They're not the older ones. So they're the younger ones who are getting lifts, usually like late 30s, early 40s. And for them, I do advise getting the jaw implant. And sometimes they do, sometimes they don't.
And you and I have a couple coming up where I'm going to put the jaw in and then you're going to do the facelift around it. Yeah. And I'm going to give you a jaw structure that I hope you can get that beautiful neckline that you're asking for.
And it really
I think
is
some
in those
patients who do have
40s.
Yeah, and those patients who don't have this, I think it does help because you're doing the skeletal and then doing the soft tissue around it and then fat on top of it if you need to, et cetera.
Yeah.
And then cheek implants is the same thing. Someone who's like deficient, giving the cheekbone up here, if it does no structure, sometimes you need to do fat or an implant depending on what you're looking for. But I've seen your procedure and facelifts. You do like to kind of contour the cheekbone with soft tissue.
Yeah, I lift it back up as high as it goes in a natural way. And when you do that, the contour is restored, the lateral cheek hollowing improves, the buccal hollowing, which is drooped down into kind of like a droopy dog look, gets cleaned up, and you can angulate the jaw and the neck better than it's ever been just merely by the positioning of the platysma. So I do, it makes a big difference on where you're attaching the platysma, whether it's on the outside of the mastoid or the internal curvature of the mastoid, and giving you that depth from the jaw. Like the jaw stays out here, the platysma tucks in, and the platysma really holds all the internal components of the neck in this compartment, and it can be sitting like this, narrow, it can be sitting like this, it can be sitting wide. So depending on how you position the platysma, it'll hold everything, all of those contents in tighter and nicer.
I love that. And I think that we're saying the same thing. Definition is key. And if you don't have definition, you have to look if it's bone, soft tissue, or fat.
Yeah. So this picture, this patient will be very difficult for me to improve with soft tissue things in general. So what did you do on her?
Yeah. So let's use her as a good example. So she comes in and she says she doesn't like her chin. Really beautiful patient, lived a lot of her life without this chin and felt that she was something missing. And you can tell that her harmony, her well-developed cheekbones, as you can see, and then you have her lips are well-developed, and then you now have this chin that is not developed. And you see how she can probably come across looking much younger than she's taking credit for. She wants to look a certain age, and she's never liked it. Number two is the neck is not draping well. Anyone has a small chin like this, you got to look at the angle of the jaw. So she was considering to do a custom implant here. I said that women can get away with the weaker jaw. We're already going to be adding so much in the chin region. I just don't feel comfortable really giving her so much of a jaw. So I said we address the angles later. If we use fillers on her, Dr. Talei, how much filler? I mean, I would have to use 2 to 3 to 4 cc's, and eventually would never push it out. It just start to widen out.
I mean, to get a big change on that, you're like, 5 syringes, and it's.
And I think that. And you agree with why? Why does she have a small chin? She's lacking bony architecture.
Correct. Yeah, lacking bony architecture. Her teeth are in a relatively good position. Her jaw itself is not one that you would consider micrognathic or microgenia, but it is kind of getting there. So
it's small. I did ask her about her teeth. She has good teeth. They're fit. So therefore, I told her she could get an orthognathic surgery to bring it forward, but she didn't want to get the sawing and the possibility of having me do an implant in the future. So I did offer her that. And ultimately what we did is I told her, let's just do a prefabricated chin implant. Prefabricateds work really well. She was on major asymmetry. I put a large or an extra large Middleman pre-jowl implant because the Middleman pre-jowls have more projection versus the EACs, which are a little bit more, just kind of the normal architecture. Yeah. I wanted to really get her a lot of projection. And what I did is I whittled it, I prefabricated, or I customized it myself towards the contours that you and I talked about. So I carved it downward and then I secured it to the base. And then this was her year result.
Yeah. And so in my arsenal, like I don't do jaw augmentation that substantially. I'll send it to you. I do kind of baby stuff, and the baby stuff, I always use either EAC or Flowers mandibular glove. And then between those, I could just carve them into, they're all small size implants, but definitely, when you get into larger ones, like, the middleman can fill you out a little more, project you a little more than those can.
Definitely.
But that's not my world. That's your world. I send it over.
Well, we all have our place in there. We all have our wins and we have our headaches, right? The more you get good at it, the more you see the headaches. So,
and I think the great thing is, also for the, people who are at home and they get to watch this stuff tomorrow, I get to talk to Octavio Sintra, who is like an incredible orthognathic surgeon in Brazil that we've worked with. And so from there, we'll get to see the differences that you can get between the types of surgery. Because you see a huge gain just from doing that. But his pictures, you'll see it's the other patient that we were talking about. Right. They do have a hypoplastic alveolus, midface, open bite deformities, things like that. And, it really gives incredible.
Yeah. And I think that'll be a good person to have on here to give perspective. I see some questions coming up, just kind of exactly that.
Oh yeah.
Her face looks longer. That is actually true. Anytime you get a facial implant in this region, by bringing it out, you will lengthen a face. So it should be equal to the third. So that's one thing I use for projection. Like Dr. Talei brought up, is that, using too much filler makes you look amorphous. This means you put the implant in the right position, which is on the inferior border. Should I get fillers? So
I'll say this. So the question here is, should I get fillers before a custom jaw implant or chin implant, let's say, to see what it will look like? And I've heard this so many times.
I know.
So how do you answer that?
I say if you want just a little bit of fullness and see what it feels like, it might drape the skin a little bit better. But I tell patients, but I don't want this to be your comparison to see if you need a chin implant. They're two different procedures, completely different results.
That's exactly what I tell them. Completely different result. If you're not interested in getting an implant for any reason, then go ahead and do the filler. But it's not. I tell them exactly that. It's not going to give you the result the implant's going to give. And then I tell them how low of a threshold I have, for doing implants.
And chin implants, when we do all use silicone, I say 3-6 months, put it in. If you hate it, which is very rare, it's removable or changed very easily.
Yeah.
And we don't have to use so much filler. And financially, I think is a good question. Remember, fillers have a cost. And when they put in, you might need 1, 2, 3 syringes. If you like it, if you do, you can keep doing it, but it adds up to something that could be permanent. And also, we both agree the better option.
Yeah. And so doing it with other surgery, I think with rhinoplasty, it's a very beneficial and powerful thing. And it's usually when the surgeon correctly assesses the need for it. The place where I've seen it incorrectly assessed is when somebody needs a facelift. They're drooping around it. And instead of really looking at the bony skeleton and realizing that the soft tissue is drooping on top of it, they look to see, okay, well, if I push the chin out, it'll look better. Like, no, you just made them look masculine and droopy now. It's, you took a woman who had a nice, perfect jawline, in my opinion, that just needed a little soft tissue redraping, and then they made them masculine. So I think it is very powerful when you do it with other surgeries, but I've seen it usually when it's done with facelift, it's done inappropriately. When it's done with rhinoplasty, it's almost always appropriate.
Yeah, I think rhinoplasty is the most common procedure in conjunction with chin implant with rhinoplasty is the most common done together. The nose and the chin are harmonized. That usually done right. Chin implants with facelifts can be done, but you got to know that you're also changing other architectures, so it has to match. You have to be going to someone who really understands those things.
Yeah.
Can someone ask you a question about buccal fat removal? Do you want to take that one?
What about buccal fat removal?
Someone wrote like buccal fat removal. And
will I get dimples or holes or nothing done to my face? So, so buccal fat removal is something that also is done inappropriately a lot of the time. Buccal fat removal is, there's a fat pad right over here, if you push your tongue into your cheek, where a little smooth baby fat that you don't really have in other areas other than your under eye exists. It's a very special type of fat. So I caution patients that it's a support structure in the face. And yes, it is rounding the cheek, but it's also supporting your marionette region. If you get rid of the buccal fat, you have the risk that this is going to look darker and deepened and in a very unnatural way, unless you're somebody who has excess. So there are some people who have excess who are overly rounded, but it's not the 17-year-old. It's usually the 25-year-old, 27, 28-year-old who is maintaining their baby fat and still looks round and pooching out at that point where you can say, okay, I'll take it in. A 17-year-old, 18-year-old, the Hadids and those types of people who did it early, they need that fat. It's going to go away soon. And once it's gone, you're screwed. You will look older than you would have looked, and you're going to have a deeper indentation here than you would have had.
And you can look hollow.
Yeah.
There are certain diseases, I don't want to bring them up, but that actually targets that region that skinnies them out. And it has a certain look to it. And that's like very difficult to correct. You can do fat transfer. You can do Sculptra to try to rebuild it, but it's a problem if you hollow out. I love doing buccal fat removal in the right patient. Sometimes with custom jaw, you want some more definition. But when I do mine, I don't know if you agree, I make the hole and whatever comes out, I'm good.
Yeah, I do
I don't
delicate. Yeah, unless I have a plan.
I'm very conservative. I've seen these videos. They just keep on going. They keep on going. They keep on going.
Yeah, It's not a diseased tissue that you need to get rid of. It's very precious tissue, and it's fat that we don't have in other parts of the face. So we're getting to an hour now. So Instagram's going to cut us off. So before they kick us off, I want to thank you for like hanging out and educating everybody. It's going to be awesome to have this information along with an orthognathic surgeon tomorrow, Octavio, and what he does. And you see really the appropriate treatment. And so patients who are going through it can see, and other doctors wake up to it, because, not everybody is like you. Like, they don't have your expertise. They don't have your taste. They kind of just throw in implants and stuff. And I think it's great to see the difference. For everybody who wants to see Dr. Dhir, you can see his Instagram is Dr. Dhir Plastic Surgery.
Dhir Plastic Surgery. DHIR Plastic Surgery.
Dhir Plastic Surgery, and website. He's in Beverly Hills, right next to me.
Right next door to you guys.
Yeah, we do work together very often, and we're hoping on training some people together as well.
Yeah, we're gonna work. Oh, we better get on that since we have time now to do that. We better get on that. Everyone out there, I want to appreciate the chance and opportunity to talk to all of you. Dr. Talei is an amazing collegial expert here in town, as well as very talented. So we do work well together, and I'm happy to be on the show, sharing some knowledge, even though I don't think I taught you much.
You did. You always do. No, you always do. I love calling you for help with these things.
Same here.